Hello guys, welcome to the Thedeliveryroom podcast. The mic is on.
The room is sacred.
Let's talk. Welcome back guys to another episode with us.
Yes.
It is Olivia
and it's your girl Claudia.
How are you today?
Today is an okay day.
Okay.
I think we're feeling okay today, you know, obviously busy as usual. But yeah, I'm trying to learn how to enjoy my days more often. I'm trying to see the light in everything. Do you know what? I like this because this, like, especially from work, I like most of my like stresses come from work. So I feel like this is always like a good unload.
Yeah.
Every time we come here and we just vent about everything, work and midwifery. So I actually always feel like a lot lighter.
That's good. I'm glad to hear that the people are helping.
Yes, and you?
I'm okay. Like you said, I don't know. I feel like the last couple of weeks has kind of been a bit non-stop, back to back, but trying to find my feet and stand tall. But yeah,
in Jesus'
I'm good.
name.
Amen,
Ciao.
Amen.
So today we are back with another one, and we wanted to talk a little bit about induction of labour.
Yay.
So I feel like we've itted and bitted, like we've dipped our pool in this one, like in a few episodes, but I don't think we've actually properly had like a good on discussion about induction of labour, and I think it's a massive thing at the moment.
Definitely deserved like a whole episode where we can properly explain in detail about
induction and just everything about it. Where do we start? Because induction is a whole other thing. I think
should we start with like why someone might be offered an induction? So the very beginning.
Yeah, I was gonna say let's start off from a pregnant woman perspective.
Okay.
Like let's not go into our midwifery mind. Midwife. So why would you be offered an induction? So
multiple reasons why.
Thousands of reasons. Hundreds of reasons.
Some of them some of them we may not agree with as midwives or personal opinions. Some I would agree to. So let's start. Should we do one each? Make it fun.
Let's go. Let's start naming. Let's name it. Should we do it as a game? Let's start naming.
Okay.
Okay. How do we do who loses? Okay.
Too much thinking.
Okay. Let's go as much as we can. Go on.
Post dates.
Large for gestational dates.
GDM metformin.
Small for gestational dates.
SG. Oh no, you just said that.
Yeah.
Diabetes. Did I just say that?
Yes, GDM.
GBS. Did they have GBS?
We don't induce for GBS.
No. Prom.
She loses.
Prom. So
the one I hate the most, maternal age. I hate that reason.
I don't think that's a valid reason.
That reason. Every time I get an induction for maternal age, I'm like,
I don't think
that's just my personal opinion. Sorry, this is not like research based or anything. That's just
personal.
Me.
Okay. I agree. I just think if I'm 38, you're gonna offer me induction because of my age.
I'll just
like it doesn't take away from a 34-year-old who you would consider low risk.
Right, IVF.
Yeah. Well, I think you've won this already.
There's low IVF, hypertension, preeclampsia.
Well, high risk women in general. Like anything that we would class high risk. I'm trying to think.
Anymore? There's just so many.
There's a lot, but you know, honestly, when you put yourself on the spot.
Sometimes there's like ones that you just made that up. Like,
like what?
Like sometimes you get one, you're just like, you just made that.
Pulled that out of thin air. You said, I'm gonna take that
today. Do you know what I mean? But so obviously there's loads of reasons why you can literally be offered an induction.
Some people request an induction.
Yeah. Actually. Sometimes maternal request. I just think that there is a lot of discourse about people being offered inductions for no reason. And don't even get me wrong, sometimes I do think that myself, but it really does depend on what you're being induced for. There are some where we can say, do you know what, if you don't have an induction, it's not the end of the world. However, there is always risks associated. However, like I said, not the end of the world. Whereas there's some where I'd be like, no. induction, I think is necessary at this point.
Yeah.
I think post-dates is the one I think might have a lot of discourse around it. A lot of people, a lot of women I hear say, you know, my body wasn't ready. I had an induction, ended up in emergency cesarean. You know, I want to give my body an opportunity to do it. I want to try. I want to go into spontaneous labor.
I heard this once, and this was the woman. I want to say, I can't remember the country, so maybe I'm not going to say the country, but she was like, why are we offering her an induction now when she named a country, can't remember, but in so-and-so country, actually women are allowed to go up to like 2 weeks more than we would allow. So she was like, in this country, women carry their pregnancy this far along, so why can't I? And that was a good argument, I'm not gonna lie. I stood there and I was like, wow. I mean, obviously we know why we're offering induction, because placental, the chances of it working. And I think it was, I want to say Kenya, but I can't remember. But obviously, the Western world were more modernized and were more quick to, you know, intervene. But that was a reason why I've heard that I was a little bit like shocked over.
I think, but in comparison, obviously it depends on what country we are comparing to, is that there's also, we need to remember that lack of research and lack of resources in other countries are also a factor. Obviously, when you are induced, there's agents that we use, a pessary, a cervical balloon, syntocin, pitocin is what it's called in like America, and other things. Other countries might not have those necessary resources to induce you, which is why they might let you go a little bit longer, maybe to reduce the amount of people that are coming for induction, because they don't have the resources, the staffing maybe to actually, you know, cover and, you know, cover all those inductions. So that is one argument I'd give against that lady. Do you know what I mean?
I just thought, first time she said that, I'd never heard anyone
you know,
say
so
that.
you're like, ooh,
I was like, oh, I'm taking back a little bit.
You teaching me.
But then obviously when you actually think about it, you're like, is that actually,
you know. So yeah, I would say that's like one factor. I'd say in terms of post dates, I think it's difficult, because yes, you can go a week further. We usually stop at 41 weeks. I think is when we offer the induction.
Which is 10 months, by the way, guys. 10 months.
Which that's in our trust. We let you go 41 weeks, and then we obviously start offering the induction. We can say 41 weeks, have an induction, you decline, and then, I don't know, 41 plus 5, you deliver, and everything is absolutely fine. But the reason for induction and why you'd be offered it in the first place is because we recognize risks associated with whatever problem or whatever issue you've got. So like, say post dates, as we're using, we've recognized that, okay, cool, you've gone past I need to start even before I come in. You've gone past your due date, right? And we're now looking at the efficiency of the placenta. The placenta is literally what keeps your baby alive. In the most brutal way possible. If your placenta stops working, that's it, game over. Like that was quite brutal, literally.
Yeah, she said
I'm sorry, it's brutal. Like, but if your placenta stops working, that's it. Game over.
No other way.
So we, you know, placental efficiency is obviously important. There's loads of research that shows that after you go over post dates, 41 weeks, the efficiency of the placenta starts to then decrease and lower.
And there is no one can say for sure today's the day it will stop working. So let's do it 2 days before. Like, which is why one knows, and everyone works differently. Every placenta, everyone's body is differently. Like, someone can go to 42 weeks, have a baby and be fine. Someone after 40 weeks, we can see signs that maybe it's not so efficient. You know, we can always tell about baby's heart rate variability and stuff and trace. And
even like we said, like obviously we start considering that as a danger at 41 weeks, but there's women that we see all the time. How many people that we get placental abruption at 37 weeks, 36 weeks, 35 weeks? Yeah. And that's someone that hasn't even gotten close to their due date. Yeah. So when we are reaching 41 weeks, we are going to be a bit like, okay, we're a bit worried about the placenta now.
We want to go as far as we can, but we don't want to push our luck too much, because the outcome is, we're trying to, we don't want those outcomes.
And you know what, like I think a lot of women that do sort of complain and are not really for induction is because a lot of these women want their body to do it themselves, and they don't want to end up in an emergency cesarean. I think obviously one risk associated with induction is that you're likely to have a cesarean section. I will be honest, this might be brutal again. I'm really sorry. I haven't had breakfast this morning, guys. So you know what? I think I'm a little bit brutal
She's
today.
Angry.
But I would rather you have an emergency cesarean than you have a dead baby.
129%.
So that's the risk that I like to weigh out. Like, cool, you might not want an emergency cesarean. Understood. And obviously, without the circumstance of trying to put you and your baby in danger, I will always try my best to accommodate that. However, if it comes to a point where we need to go for an emergency cesarean, I would rather we're picking life, and that if that's an emergency cesarean, that's the route that we're gonna go down.
Because at least you get to hold and cuddle your baby. Like listen, at the end of everything we do, is a healthy mom and a healthy baby. We go through so many different channels, but at the end of it all, and I feel like every obstetrician, every midwife, that is the main outcome. Like, that is what we want. So we're not going to stand by and watch you make decisions that you're risking your child's life. I've seen stuff before. I've seen stuff where I'm holding back tears because I'm like, this is not going the right way. And you have parents that I'm not trying to
how many times do you have something happen or something go wrong and you're like, this could have been prevented? Like, so many times. And you fight yourself and you're like, did I give them enough information? Did I convince her enough? Did I, you know what I mean? And it's like, yeah. So I would say, like, in terms of post-dates, yes, like, there can be an argument that it's not necessary. But like we said, we don't know when your placenta's going to stop working. So with induction, I can't say, or we can't say, you should have an induction or this will happen. It's more so, you should have an induction because this could happen. And I can't tell you that if you do not get induced, that this will not happen. But obviously a lot of cases with induction can be argued. Like, for example, I think LGA is another big one because I feel like the main focus is obviously shoulder dystocia and baby not fitting through the birth canal and things like that. I think I saw someone on TikTok actually say that, oh yeah, but my baby could have had a shoulder dystocia anyway, even if I wasn't LGA, which is fair point. Fair point. I'm not gonna lie to you. Fair point. However, if the baby is already big, the shoulder dystocia, the rates of it is higher. The rates of the baby not surviving it or us having to potentially perform a procedure that comes with 100 risks. Yeah. With you, life-altering ones, is higher with a bigger baby. I think sometimes, yes, we do have babies that do have shoulder dystocia, and sometimes all it takes is a Mac Roberts and dislodging the posterior shoulder, and it's like, whew. But with a bigger baby, we might have a little bit more trouble solving that.
And you might have to theatre to solve it.
Yeah, and time is ticking when that happens. People just think the baby's stuck. No, like every second counts.
Shoulder dystocia is scary.
Like, because you're literally
so simple, but guys, it's so funny. But we're speaking about, well, it's not funny, but we're speaking about this because actually, I actually watched a woman's birth story. She's in America whose baby had shoulder dystocia passed, and she was doing a home birth.
I saw this. Yes,
and it's so sad, but it's one of those things where it can either resolve easily or not. And it turned out that her baby was really big, and it was just not coming down the pole. And there's nothing no one can do to prevent that, because the baby is just not fitting down that is the anatomy of the body. Like, there's literally nothing we can do to change that. So it's very. I've always said, hands up, if you tell me my baby's on 100% child, book me in now.
Get me on the table.
The scalpel myself.
Get me on the table. Like, I'll even bring the baby on my own. I'm not playing.
Shoulder dystocia is something I am not playing
I'm not doing. And is the reason why when you are large for gestational dates, you're offered an induction at really early. So before you even hit.
Yeah, because the baby's growing. If the baby's getting bigger.
You know
and bigger.
what I mean?
Yeah.
But yeah, so we do obviously have that. And like we said, like, bro, shoulder dystocia is freaking scary, bruv. You do not like I'd hate that to be me. I hate it. So
and things have to happen so quick because again, it's like cutting the oxygen and then hypoxia and
how many times do you see a baby going blue in front of your eyes because it's just stuck?
And you're trying and there's nothing working. Like, you do not want to be in that position. Yeah. So if you're told your baby's big, please take it into consideration.
Yeah, take it into consideration. Obviously, sometimes, and let's also remember, I think with small SGA and LGA, is that they're obviously measured by scans. Scans are not always 100%. Accurate. Yes, that is actually a fact. Scans are not always accurate. However, it's an estimate. And I think an estimate is better than nothing or not knowing at all. So I think sometimes let's just go by the estimate and go from there. Yeah. Obviously, again, hey, it's up to you. No one can ever force you. But I'm just a fan of prevention is better than death, essentially. Yeah. So
better safe than sorry, we say.
So yeah, so I think that kind of covers like what induction or why it's offered.
Some
and
reasons
there are a lot of arguments and a lot of people, and I've had beautiful induction experiences,
and sometimes you don't go through all the hoops that induction is. Sometimes the first induction method works for you, and sometimes obviously there's no saying that which one would work for you, but sometimes if you have the first one, it goes quickly and you go into labor and your body takes over and boom, you're done. Sometimes you might have to go through all the steps to get to the end, and sometimes it does fail, but it's all an attempt to try and get you to have a vaginal delivery rather than jumping straight to a cesarean section.
And I'm not gonna lie, like inductions can be traumatic, it can be traumatic. So going into obviously stages of induction, so obviously you'd be asked to come in, usually is a ward. You come into the ward and you are first like reviewed by the doctor, and then you're assessed by your midwife. So obviously depending on the consistency, the length, how dilated your cervix is, will then determine what route of induction you sort of go by. Some people go by both. Some people have one. So we have a pessary, which comes in the form of pessary and it comes in the form of a gel. You know, some people have the gel.
Prostaglandin gel.
Sorry, so our trust just uses the pessary. So I'm just going to talk about the pessary because that's what we use. So essentially, it's literally just like a flat tampon. Like it's not as big or thick as a tampon. It's like really flat.
It's literally like this big.
We should start bringing props in.
Yeah,
and actually show it. Yeah,
I always show.
I always say, do you want to see it? Like, I would like to see what's going in my body. I mean, so I always say, like, can you bring it? So, essentially, this is a flat pessary that is tucked behind your cervix. So the aim of the pessary is to basically try and improve the consistency of your cervix. So I think some people get confused. They think that it's meant to help you dilate, but it's actually not. It's meant to actually just get your cervix more prepared, basically.
Shorten, come to the front
and soft. Yes, it might make it open a little bit, but that's not the actual aim of a pessary. It's the balloon that actually helps actually open the cervix a little bit more. Where the hormone drip, oxytocin, is what's actually used to actually help you dilate. Anything else before that is to prepare your cervix for that stage. So I think people get confused and think that they're meant to be dilating in that first stage, but it's you're meant to dilate. We want you to dilate to at least 2 centimeters, so where we can break your waters, but it's not meant to take you to 10 or 5, or you know what I mean. Sometimes it can,
but not always. And it's good to have that in the back of your mind actually, so that you can prepare yourself. If I'm doing this, I'm just prepping myself, just so you know what kind of stage you're at. Because some people come in, have the pessary, and when they have it out, they expect to be like 7 centimeters. Funny, but it's just not always the case.
Not always the case at all.
Like a lot of,
and barely the case.
I feel like a lot of labor, birth, pregnancy, it's just mental preparation actually, like maybe life even.
So we obviously so pessary has basically prostaglandins that basically release, and basically help.
That was it.
Yeah.
Job.
Oh, is it? Yeah. That help. Yeah. So releases prostaglandins to basically help the cervix to then, like we said, change the consistency and stuff. So yes, they can cause contractions, because obviously the prostaglandins are then released, and
the
hormones, and
just,
it helps everything get going, and it stimulates the oxytocin in your body. So yes, it can cause you to actually dilate. Obviously there is the risk of contracting too much. Hyperstimulating, which would then be cause for it to then actually come out. And these are the type of things that can make the induction process a little bit longer, because obviously we have to take it out because we don't want to distress your baby and you as well, and overwork your body, which can lead to like risks of like bleeding more during delivery and things like that. So we obviously would have to take out, and we do have like a reversible injection and a little antidote that we give to slow those contractions down. So that is what you'd be offered if your cervix wasn't dilated at all. So if it was closed, and if your head, the baby's head, was something called blottable. So this is where we can literally basically boing the baby's head up and down. Literally, when you're palpating, you can literally move the baby's head out of the pelvis, so it's not actually properly fixed and engaged into the pelvis. So yeah, I forgot what I was gonna say. I was gonna say something. Anyway, can't remember. But yeah, so then we have. Do you want to explain the balloon?
So we have something called a Cook's balloon. We offer it in our trust. I'm not sure if it's a universal thing and all hospitals offer it, but it's a non-hormonal way of kind of inducing. So you can only have the Cook's balloon if you're at least a centimeter dilated. What the Cook's balloon is, it's a long plastic tube. It's kind of like the thickness of a pen, if that. And
I think it's a little bit thinner.
Yeah, just under. And so you need to be at least a centimeter. And what we do is we feed it through to your cervix. And the purpose of it is quite literally a balloon. We inflate it with some water. And we do about 60 to 80 mils of water. And there's 2 balloons. So we want one to sit inside on top of your cervix and one outside. The purpose of it is that you've now got 80 mils of water and your cervix in the middle to apply some pressure to help it dilate, like Phil said. So it's a non-hormonal way of inducing labor if you're at least a centimeter dilated. Obviously, if your cervix is closed, there isn't that entry for us to put it through into your cervix. So then we can't offer that method. I am a big fan of. I think they were uncomfortable
to get a balloon in. Everything.
I feel like it works
the best.
It stays in for about 12 hours for us.
Yeah. And I forgot to say the pessary
initially you just walk around and you just hope that it's just putting enough pressure to dilate. And I love it when someone comes to me and say, it fell out.
Yeah,
like, we're doing something, because it essentially means that your cervix is opening enough that the balloon has just fallen through. So yeah, what I say about Cooks, I think they can be uncomfortable inserting them.
I think everything about induction is uncomfortable. Just labour and
pregnancy is uncomfortable. But once it's in, it's like a little strap we stick it to your leg and you just walk around. Some women start to feel crampy with it, so it might settle. Pressure. Sometimes it doesn't. It might actually start contractions as well. So yeah, I'm a big fan of
I'm
for a Cooks. Like,
I think most of the time Cooks work.
Yeah,
like most of the time. I think with the pessary it's a little bit more difficult, because although it can cause like contractions and everything, there's just not enough to get the cervix where it needs to be, I think. And I forgot to mention that a pessary stays in for 24 hours. So obviously the process is obviously longer. Which is just, you don't want to keep the woman in for as long as you can. You want them to move along to the next stage as quickly as possible. And I think having a pessary is obviously 24 hours. It's just long.
And just to add to that as well, sometimes you can have a second pessary put in if the first one didn't work as well as we would want to. You get like a 12 to 24 hour break and then you move on to the next one. So like you said, it is lengthy, because if you've had the first pessary for 24 hours, then you have a potential 24-hour break. That's 2 days already. Then you have another 24-hour pessary. That's 3 days. Kind of at the same stage, same level. and then potentially move on to something else after.
So it can be disheartening.
Can be lengthy,
I think talking about the length and the time of induction, guys, you have to be, I'm not gonna lie, like if you're going for induction, you have to be ready to, I'm not even stretching it a week.
Yeah,
potentially
including after delivery,
just because you just don't know how things will go. I would say a week. Like prepare yourself to at least maybe be here for literally a little staycation with us, because it can be lengthy, and that's not always just down to the procedure itself. It's the availability as well. Of actually
sometimes
getting
the activity is so high that an induction isn't crazy. Quite the priority when you've got a 7 centimeter woman walking through the door. We have to
we have to measure out the priorities and see, obviously what we're going to prioritize. Like in the nice way as possible, we cannot prioritize someone that's 2 centimeters waiting for their waters to be broken.
You're happy, you're
not
safe,
doing anything, you're
safe.
fake. Yeah, well, obviously we monitor you regularly when you're being induced, so we know that baby's okay. Obviously, you're in hospital. Like you're not doing anything at that stage. We cannot prioritize you starting your induction over someone that's coming in active labor 6-7 centimeters
that could potentially deliver a number of hours.
Like, we can't do that, and I think it sounds harsh, and it makes it feel like, oh, maybe the inductions aren't as important, but that's not the case. It's just a priority. Like if someone was standing, it's like having 2 people in front of you, and I don't know, let's say, you were in Sainsbury's and let's say in a scenario, like let's say cool, you have an ambulance and then you have someone that's in a car. The ambulance obviously has the blue light, I can get to the hospital quicker. If you have an induction that needs to go to hospital, that's 2 centimeters and then you have someone that's actively, who are you going to put in the ambulance?
You're going to put the woman
that's in active labor in the ambulance. So think of it like that. And I know it sounds annoying, especially if you've been waiting for days, because sometimes you can be waiting for ages, like up to like 3-4 days. I know. I'd hate it myself, like being in that closed space for that long. However, you need to remember there's so much entry points. We have people coming in from triage, people that were already in labor, and then we have people coming from MDU as well. Like people are coming from all areas. We are not just banking on the people that are on the ward that are, ready for their waters to be broken.
And sometimes you could quite literally be the next one. The midwife is on the way to get you, and then someone walks in, and boom,
and we have to move things around.
Has to change. It sounds unfair, but it is a public service. It has to go in order of priority.
Yeah.
And God forbid, but if you were in a situation where it was emergent, you would want us to prioritize you over others that may not be in that situation. So,
and guys, honestly, I feel like that's where we get the most heat. Like when someone's been waiting for ages, and they will literally go off on you, like, trust me, I want to get you over too. Like I'm not keeping you here, but there's no point in me. Like even when people are like, oh, get me over. If there's no midwife to look after you because they're all looking after active labourers, even if I take you over there,
there's no
you'll
point.
be doing the exact same thing that you're doing here, which is sitting. And there was one time, someone called the police.
Do what?
Called the police to the ward because they were saying that we were basically holding him and his wife hostage, and we were refusing to look after them. We were refusing to take them to delivery. This man called the popo. He called the police. I said, now, why are you wasting emergency services like that?
What?
Yes,
Sir,
people
go
get
home.
I don't think people understand the madness that we deal with sometimes. And it's like, mate, like we are not doing this on purpose. Some people scream, swear, insult us, say that we want to kill them and their baby. Like I've heard outrageous, people say outrageous things. And I understand that people are frustrated, especially if you've been waiting like a couple of days, like just to go over, and you're ready for your waters to be broken. Like I understand, I get it, but there's only so much. There's only so much I can do.
And they don't understand. And also, we're human. When you're standing on our face, Shana, saying that you're gonna let her die, you're gonna let baby die. No. We are human. We are quite literally trying to prevent that. We want what's best, but I just feel like people have no sympathy to us.
Not even just sympathy. I think people also fail to recognize that they're in a public service.
You are
that is not just catering to just you. This NHS, we're literally catering, as we are here, we're catering to every single person there are others that are being induced as well that may be a little bit more of a priority. Sometimes we get
you
stroms.
have to rag rate them.
Yeah, sometimes we have stroms, people whose waters have been gone for more than 24 hours waiting. And it's like we have to wait out. So yeah, guys, be ready. Sometimes you will be waiting some days, and unfortunately is out of staffing control. We would never keep you if we don't need to.
Trust me, we want you to go home.
Yeah. And enjoy your baby and enjoy your labor. But yeah, so I think that's like sort of like the first part of being induced.
So once you have gone on to labor ward, so this part is usually done on the antenatal ward. Once you're on labor ward, there's two kind of ways induction can be done. One is artificial rupture of membranes. So if the propers has done what it needs to do to shorten your cervix and bring it forward, and then or the balloon has dilated you at least 2 centimeters, you will be taken to the labor ward. Again, each hospital to their own. I'm not saying you will be taken as soon as you're made 2 centimeters. Some people have a waiting list. It's not always like we've just spoken about, it's priority. But once you are there, ARM, artificial rupture of membranes, is basically us examining you, feeling the membranes, so the membrane sac where baby is in, where the amniotic fluid is in, and we're basically breaking it. We do so with a small plastic hook, and I know hook sounds scary, but the amount of times I have shown to my patients, and they're like,
you can barely see it, like you can barely see it.
It's quite literally, and I always describe it as, imagine having a balloon with water in it, and you put a tiny pin in it to help the waters leak. That is what we basically do. We feel for your cervix, we feel for your membranes, we go in with the hook and we break it. We just put that little kind of hole in there. And that is just to allow the waters to come, because that stimulates more, stimulates the labor. It allows more pressure to be put on the cervix, because now that little cushion that baby's head was on isn't so much there anymore. So it's very important, if that's the next stage. It's also important for us to like assess the water, the fluid. So sometimes it's meconium, which means baby's done a poo in, which is more concerning, needs more kind of observations. Sometimes it's clear, which is what we would want. Sometimes it might be a bit bloodstained, which can be normal if we've just kind of irritated your cervix. If it's heavily bloodstained, then we have to think, is the placenta not working or what's kind of happening? But yeah, essentially that would kind of be the next step. Breaking your waters, sometimes they will, depending on the trust, they will give you 2 to 4 hours to walk around and see if things pick up, especially if you've been contracting prior. Sometimes they might want to start the next stage of induction kind of straight away, which would be the hormone drip.
This is a lot of people's enemy.
It is a lot of people's
hormone drip. Like, I will not lie, the hormone drip is harsh.
It is harsh. It comes at you. Fast.
Natural labor. Let's say natural labor is a build up. It sort of starts off, maybe Braxton Hicks. Very early labor, sort of like period cramps, and then it builds up and becomes to contractions and becomes intense. Whereas the drip just goes boom, straight contractions. Like, you don't get that build up. So we do get a lot of women that do have the epidural with it, but trust me, I've seen women do it without. When you have women that do it without an epidural, I'm like,
you are a soldier.
You are a
or sometimes they're contracting and you're on a high dose and you're looking at them, are you okay? And like, and I'm like, hey.
Like some ladies do it. Like, it's not, I don't think it's necessary. Obviously, your own pain tolerance, but I feel like a lot of people say, oh yeah, if you get the drip, you have to get an epidural, but you actually don't. You actually don't. I have seen plenty women deliver without an epidural, so it's possible. But you do have that option of happen if you know that you can't take the pain, or you've had it before and you know how it goes, and you know that you ain't with the pain. You can have an epidural beforehand, before starting anything, and you can have an epidural during as well. You can also start off with the drip, see how you go, and then decide.
Which is what most people do.
It's titratable, so which means that we can increase and decrease the levels, and we can also stop it as well.
And your body
it flushes,
it quite quickly.
It flushes out the system quite quickly, so we can actually stop it and get your epidural in, get you comfortable, and then sort of start it again. Obviously the risk associated with the drip is baby getting distressed, maybe not be coke, hyperstimulation, and then obviously there's the risk of cesarean section as well, which I think is what a lot of people fear and are worried about. But yeah, the drip is a lot of people's enemies. But we start off at a very low rate as well.
Very low.
Also, there's different factors that also will depend on like what rate we start off at. Let's say if you're a VBAC, so that's vaginal birth after cesarean, we will start off at a very low level because we just want to avoid the risk of stressing out your scar basically, and avoid the risk of it rupturing. And then obviously we have women that have had multiple babies before as well, that we tend to start at a lower level. Obviously another risk that's also associated with the drip is also bleeding. A lot of the time when you are induced, it is very likely that you might be in labor for a very long time. So your uterus has been sometimes continuing contracting for like more than 24 hours sometimes. So when it does come to that time where it needs to contract back, it
might just need a bit of help to just help it contract, because if not, you bleed.
You quite just continue bleeding, which is obviously that risk. I just think induction, it's just a weighing out thing. Like I don't think it's always necessary. Like, and I feel like a lot of women are looking for a straightforward answer and are also trying to create straightforward answers and say you don't have to have an induction, but no, sometimes you actually do need to have an induction, and sometimes you don't. But I don't think there's a solid answer as to should you have an induction
or should you.
It's off. That's why we call it offered an induction. It's never you have to have an induction. If you don't, it's offered.
Nothing is should be forced on you. It is your decision, your care at the end of the day. But like we said, everything is offered, and it's just up to you to take the information you're given, weigh out your pros and your cons, the benefits, and make an informed decision about your care.
And we do have sometimes like pregnancies where you didn't have to be induced, and then the next one you do have to be induced. Or sometimes when you was induced last time, you don't have to be induced this time. And I think that comparison that we're always talking about as well also, impacts the way women make their decision. Like you have people on TikTok in the comments under someone's video that may be questioning having an induction. I had an induction and it ended up in a cesarean section. I had an induction and it didn't work. Yeah, but that's for you. That is for you, not for the lady. So I think sometimes when people hear, oh, I had a friend that had an induction, it ended like this. Yeah, fair. You could have had a normal labor and ended up in a cesarean as well.
100%.
So 100%. Honestly, there's always that risk of, I think I'm speaking on cesarean because I think that's a lot of women's issue, especially if they're not leaning towards that way, is that they're afraid of having to end up in an emergency cesarean section. You can literally end up in an emergency cesarean even in natural labour as well. 100. It's not to say that it will happen or it won't, but there's still that possibility. So I don't think that should be the sole reason as to why you make a decision. Whereas entirely, I don't think that should be the whole reason why you make a decision whether you want to have an induction or not. There's other contributing factors that you should think about in order to make a proper decision.
That could be more prominent as well. Those factors. But that is the main stages of induction.
So
really.
We've gone through the main stages of induction. We hope that this has, helped and informed someone. Obviously, just remember that every trust works differently.
Yes.
Not and also everything is universal.
And we're not giving out this any is advice. Not you need to speak to your doctors and your midwives about your care. This is not personalized or catered to anyone. It's just kind of us putting general information out there. Definitely do your research and ask your doctors and your midwives about your
about your care. And that's it from us. So obviously follow us on all our social media. We are on TikTok, Instagram, Spotify, YouTube, everything. So make sure you follow us, subscribe to our channel, please don't forget, and we hope to see you guys next time. Bye.